Did we mute Dr. Singhvi? No, Dr. Singhvi, you're muted. Can you unmute yourself?
Okay. Good evening, Dr. Kaiser. Good evening, Dolores and staff, and good evening, members. Thank you for joining us for our monthly physician-to-physician call with our public health officer, the dynamic Dr. Cameron Kaiser. This call gives us, the local physicians, a COVID-19 update and the opportunity to ask questions and get up-to-date, up-to-the-minute answers and information. I'll hand over to Dr. Kaiser.
Thank you, Dr. Singhvi. Good evening. Today, the statewide CalReady system is showing discordant data, so there is no countywide update for this Thursday. But yesterday, we added 183 new cases and one additional death for a total of 291,675 cumulative cases and 3,941 deaths due to COVID-19 in Riverside County. A grim public service message from our Vital Records branch. What the state calls decedent management remains a substantial concern, and there are still significant delays in cremation and funerals. So please complete your attestations promptly if you are the physician of record in order to expedite this process. The so-called UK variant B.1.1.7 continues to circulate in the United States, and the limited data available so far suggests it does indeed cause a higher likelihood of hospitalization and death. But the earlier prediction it would become the dominant strain in the United States by this month so far has not yet come true. We do have some limited sequencing capability at our disposal through the state, who is sequencing about 6 to 10% of statewide samples currently. The so-called Brazil P1 variant remains an emerging concern, as is the so-called South African B.1.351. All of these involve the N501Y mutation to the viral spike protein, which improves its avidity and ability to enter cells, translating into greater ability to spread in real-world circumstances, and the state considers all three to be variants of concern. Fortunately, Pfizer is unaffected by B.1.1.7, and Moderna is probably also unaffected, though a new form with an E484K mutation, possibly allowing some immune escape, is being surveyed. Unfortunately, B.1.351 does seem to at least modestly diminish J&J vaccine efficacy. It severely impairs AstraZeneca in the data available so far. It does also seem to have an impact on Moderna and Pfizer, although rather less so. P1, unfortunately, is still a big question mark, and we don't have much clinical data on it yet, although data from Brazil suggests that it may be a risk for reinfection. The California variants B.1.427 and B.1.429, however, are still the highest variants in the state by number, up to 45% of samples being B.1.429, about 15% B.1.427, with B.1.1.7 and B.1.351 less than 5% each. The California variants are considered variants of interest and may show some questionably increased transmissibility, but their effect on vaccine is unknown, although the L452R mutation seen in these variants may allow escape from bamlanivimab if used as a monotherapy. We don't know if this is the case, however, for the other variants or for other monoclonal therapeutics. Nevertheless, the presence of the variants, of course, does not change our advice to the public, and we still recommend all the usual precautions. Riverside County remains officially in the purple tier with an adjusted countywide new case rate of 8.3 per 100,000 population, which is down from 11 last week. Governor Newsom indicated in his State of the State speech that the threshold for entering the red, less restrictive tier will move from 7 per 100,000 to 10 per 100,000 if the state administers at least 2 million doses in its high priority vaccine equity regions, many of which are in Riverside and San Bernardino counties. And if that occurs as soon as tomorrow, which the governor seems to expect, then based on our continued declines in new case incidence, Riverside County could enter the less restrictive red tier again as early as next week. This would increase retail capacity from 25 to 50%. It would open restaurants and movie theaters for indoor operations at 25 or 100 people, 25% or 100 people, whichever is less. Open gyms and fitness centers for indoor operations at 10% capacity, and various other changes. Effective April 1st, amusement parks may also open in the red tier at 15% capacity with other enumerated restrictions, and live outdoor events with assigned seating may also open at 20% with other restrictions. We are looking at the youth sports guidance to see how that would affect the spectator policy. In addition to our stocks of Moderna and Pfizer, we do now have a quantity of the single-dose Johnson & Johnson vaccine in stock and have started to deploy it to our county sites. And as far as I'm concerned, the Janssen or Johnson & Johnson, depending on where you see it, is as good at preventing serious disease, is easier to handle, it's easier to manufacture, provides protection with a single dose, and we will administer doses based on what we have in stock, treating all three vaccines as effectively similar in efficacy and outcomes. Unfortunately, many of you are aware there is presently a national production shortage of Johnson & Johnson, and the state does not envision receiving more doses of it in the near term, so we will be continuing on with the two-shot series until then. To date, Riverside County residents have received 609,788 doses, including those doses administered to county residents from other counties, plus doses from separately allocated multi-county entities such as Kaiser and those federally supplied contractors such as CVS. You'll note this actually exceeds our 592,880 doses received. 293,000 of those are handled by public health and 299,825 go directly to providers. And I think that demonstrates that the county is trying as hard as we can to push it out as quick as we get it. Supply as a whole, unfortunately, continues to be the most significant problem and not vaccine enthusiasm. However, we are streamlining our county procedures so that individuals who get their first shot at a county site will continue to receive an expeditious invitation and reminder for their second. Currently, we have 13 county and state sites, 5 mobile teams, and over 100 registered providers in the community. On March 15th, vaccine eligibility will start including people aged 16 to 64 who are severely disabled and/or with other health conditions that put them at risk or severe disease from COVID-19. And I realize many of you on this call are already under siege from your patients asking for these letters. And I've gotten these requests myself, both from my own patients and from the community. This would include the disabilities and chronic diseases that you would typically expect, but it also includes certain mental health conditions as well as schizophrenia, since these are often associated with other chronic diseases themselves, as well as those that atypical antipsychotics may induce, such as diabetes. On Monday, the Department of Healthcare Services issued a letter to behavioral health providers indicating that letters only need document that the client has a high-risk status. It does not need to specify a specific diagnosis nor the type of disability. Likewise, CDPH today indicated that for public sites such as our county ones, patients should bring documentation of what the state calls, quote, an eligible condition, such as a letter or document. Now, as a practical measure, since it's going to be our nurses on the back end actually looking at these, as a county, we're taking the policies essentially going to be on your honor. We're going to assume that the referrals you are making are not inappropriate and take those referrals at face value. If you think they need it, then supply permitting, they're going to get it. Speaking of vaccination, CDPH has indicated that they will align with CDC guidance for screening and quarantine of fully vaccinated individuals, but I note for the record this is not out yet. We expect that they will adopt the same guideline that those at day 14 past their last dose through at least day 90 are exempt from quarantine, and this may be extended to other aspects of case investigation. The concern, of course, is balancing the desire to give people an incentive to be vaccinated with the concern that those who are unvaccinated and don't want to be vaccinated will take this as license to discontinue precautions. However, an encouraging signal is the advanced data coming from Israel, which, as many of you know, has been a real leader in getting the portion of their population vaccinated, that suggests the Pfizer candidate, at least, is 94% effective in preventing asymptomatic infection as well. And if this translates into a similar reduction in transmission, as it would seem obvious that it would, this is a good argument for the former rather than the latter. In a like fashion, for those of you working in skilled nursing facilities, please keep an eye out for all facilities letter 2022-6. As SNF and long-term care residents were among the earliest to be vaccinated, this AFL recognizes that the risk is lower now in those settings, and I'm quoting here from the AFL directly, quote, CDPH recommends a cautious and gradual lifting of certain restrictions while remaining vigilant for breakthrough infections and transmission in SNFs through ongoing surveillance and testing, end quote. In particular, this makes visitation possible again with precautions for fully vaccinated residents or those vaccinated or partially vaccinated residents in so-called green, that's the unexposed or recovered, or yellow quarantine regions of SNFs as defined by HHS in California counties that are either red, orange, or yellow. Since we're still in the purple, this would come into effect when we hit the red tier. Similar guidance for hospitals and acute care facilities is also being worked on. I know we have a schools question leading off, but I'll comment on this beforehand. I approved our 12th public district to reopen just this morning, and 13 are either approved or open, which are Desert Center, Palo Verde, Murrieta Valley, Desert Sands, Corona Norco, Romoland, Newview, Riverside USD, Alvord, Lake Elsinore, San Jacinto, Temecula Valley, and Menifee. In addition, besides the 13 charter and private schools, which the latter largely from the Catholic Diocese that I approved for reopening in this cycle, most of the rest of the county's private schools were already in operation or open for all grade spans during the county's brief period in the red tier prior to the winter surge. Assuming that the county enters the red tier next week or following, at that point, schools and districts may open all grades as they deem appropriate, as long as they follow Cal OSHA consolidated guidance, and no approval from me as a health officer is required below the purple tier. Recently, Governor Newsom signed AB 86, which also provides further funding and incentive opportunities for districts and qualifying private and charter schools. Youth sports guidance and requirements were also revised based on the recent legal settlement announced last week, and there is a path for both indoor and outdoor sports, although indoor settings naturally carry more risk, and a testing requirement may apply depending on the venue. Lastly, the questions around Blue Shield, the contracted third-party administrator, I regret to say are still not well resolved. I know we have some questions about that later. Unfortunately, I'll just say right now, the county is largely out of that picture, so we have little opportunity for control. Only one county has signed with the TPA, but the state is still committed to moving ahead with them anyway, and all that implies, including MyTurn, and many providers do actually have contracts with MyTurn, including in Riverside County. As a result, although the TPA is primarily focusing on currently contracted providers, it is in negotiation with new ones, and if your practice registers, you will be having discussions with them instead of us or the state directly. From your perspective, the process is generally the same, but at least as of right now, you do need to have a contract to join MyTurn. Blue Shield has indicated that they plan to change this. Accenture, which is handling the support side, however, is still requiring it. We were just on a call with Blue Shield yesterday, and they reiterated their intent to improve the process for providers, but I do not have any timelines or specifics on that just now. With that, that concludes my monologue, so I'll hand it over to Dr. Singhvi for the questions.
Thank you, Cameron. The first question is a rather long question, but I'm sure you'll have answer for that. There have been many schools in our community and surrounding counties that have been back to school for months. There has been no evidence of a spike of cases or another wave of COVID secondary to those schools. The CDC, WHO all recommend returning to school. The science points to returning to school. Why are we not returning fast and in a more robust way? Also, why are playgrounds open in our community and not at school? CDC has long stated the virus is not likely transmitted on surfaces, and these kids will leave school and many will go right to an open public park to play together. Can you help us as providers and parents understand this better? We are starting to follow the science, but we are not following the science or the leaders of our medical communities in a fashion that is providing mental, emotional, and physical relief to our kids.
As I indicated in the monologue, the schools are opening, and a number of them are already back in session, and I might point out already generating complaints or adjudicating, but fortunately for largely minor issues. For example, Riverside Unified and Corona Norco Unified, which are our two biggest, are already operating elementary education, will likely add grade span 7 to 12 in the red tier. But I also want to stress that our private schools and our public school districts are independent entities, the latter in particular overseen by separate elected officials. I can order them to close under state law, but I cannot order them to open. And during the purple tier, while I have a specific role in approving their TK through 6th grade reopening plans, I won't ask them to do more than what the state requires. I won't sign off on junk either. People hear that the CDC recommended returning to school, and they did, But they also conveniently forget the second half of the sentence where it still needs to be with precautions. And I think we've seen circumstances where, there were schools that followed them and they ran very well, but the schools that did not had outbreaks. With long COVID, MIS-C cases, which are still being seen now and again in pediatric populations, I'm certainly not going to demand that any school open that doesn't feel it can do what's necessary. And as a practical measure, I don't have any pull in making them. But funding is available as an enticement. Case numbers are going down and parents and teachers are getting more comfortable. I think that question demonstrates that. As far as I'm concerned, the process is unfolding as it should. We're introducing a lot of kids into, spaces which have not had them for a while. We're trying to learn what all that means. Yes, there have been successes so far. And I think that if we continue to hold the course and do this in a straightforward and logical progression, then I think we can get them open just as we've already been doing.
Thank you. The next question is, now Blue Shield is the selected vendor to distribute the vaccines. What should I do in order to receive some vaccines for my patients?
Actually, Dr. Singhvi, why don't we take the 2 and 3 together, because the answer is going to be similar for both.
Many physicians' offices are willing and able to host vaccination sites, but it has been impossible to work through My Turn to get registered and or approval in order to receive the vaccine. We have tried working through the county, CMA, and My Turn to no avail. What do you suggest we do to try and help patients?
For providers who want to enroll, you'll do basically the same thing you're doing now through the same process, except the system is now called MyCAVax instead of CalVax. I will post the link in the chat. Just a second. Now, from the provider perspective, this is currently unchanged other than the name. If you already signed up under CalVax, then you should have already been transferred over. Do note, however, that Blue Shield is not dispensing vaccine to non-enrolled providers at this time. Now, as I mentioned in the monologue, unfortunately, we don't have control over this process. The county does not have a procedure role in onboarding, and it is entirely a function of the third-party administrator. There is technical support options for providers, however. Accenture is currently the contracted one, and they do offer technical support for it. Their email address, and I'll also put this in the chat, is mycavax.hd@accenture.com, or you can call 833-502-1245 option 2, and that will get you access to their technical support line, which is designed to specifically cater to providers trying to navigate that system. We do have regular discussions with the third-party administrator, especially as we are a Wave 1 county as defined. And we are well aware this is not serving providers particularly well. It's not really serving the counties all that well either. However, the state has determined this is the course they're going to take. So we'll do our best to try and goad them into providing you better service.
Thank you. Next question is, it is true that when a physician's office registered with My Turn to provide vaccinations, that they will have to provide shots to anyone in the public versus just to their patients? If so, question A, is there funding available to help offset the cost of providing this service? Question B, what will be our liability? Question C, does this create a doctor-patient relationship?
I'm going to leave C alone because I'm not an attorney and I don't know personally of any case law that applies. And that one may actually be a better question for the AMA or CMA councils. I do, however, think that the best overall way to characterize the situation is the same or similar responsibilities and requirements as if you were a vaccine provider under the federal VFC program. The CDC agreement, and this is required to sign up, says the following, and I'm quoting off the form directly. The organization must administer COVID-19 vaccine regardless of the vaccine recipient's ability to pay COVID-19 vaccine administration fees or coverage status. Organization may seek appropriate reimbursement from a program or plan that covers COVID-19 vaccine administration fees for the vaccine recipient. Organization may not seek any reimbursement, including through balance billing, from the vaccine recipient. That said, CMS also says that providers, and again I'm quoting from that, administering the vaccine to people without health insurance or whose insurance does not provide coverage of the vaccine can request reimbursement for the administration of the COVID-19 vaccine through the Provider Relief Fund, end quote. The Provider Relief Fund does provide claims reimbursement to providers who have conducted testing, treatment, or vaccination for COVID-19 to uninsured or underinsured individuals. This is a HRSA program. I'll paste that in the chat. Blue Shield does have an email address for prospective providers who have questions about that specific agreement. VSC in general requires you to, at least as much as possible, deal with comers as they take them. And I interpret the way that they have the contract currently structured to mean the same. If you want to hear that directly from the horse's mouth, though, they have an email address. It's COVID Vaccine Network at blueshieldca.com. I'll paste that too. And that address is specifically for providers who have questions about contracting, and they're not currently contracted with them yet. They would like more information about what it entails, and you'd like to ask those specific questions. I do point out for the record, I actually tried to run this question through them. I have not heard back from them. Hopefully that's not a poor sign.
Thank you. Next question is, when do you expect Riverside County to move to the red tier, and what will happen then?
I think I hit that primarily in the monologue, but just to reiterate, we're hoping as early as next week, possibly the week after at the latest as trends hold. And to repeat what that involves, it would primarily increase retail capacity. Restaurants and movie theaters would be open for indoor operations at reduced capacities. Gyms and fitness centers also open for indoor operations at reduced capacity. And then with the recent April 1st changes, it reopens amusement parks at low capacity and live outdoor events with assigned seating also at limited capacity.
Next, all the varying levels of criteria for people eligible for the shots are confusing. Can you please explain where we are and how to manage patient expectations? When people with chronic conditions or disabled people become eligible regardless of the age criteria, who is responsible for decision qualifications? I think you already answered that, but can you please repeat?
As mentioned in the monologue, you are the one responsible for those qualifications. We will not second guess your determination. We do expect that you're going to be reasonable about it and not sign a whole bunch of medically vulnerable notes for people who may have a questionable indication. We still do have a vaccine shortage after all. But if you provide such a letter or documentation, and it can even be a form letter if you're trying to reduce that impact on your practice, our current policy is we will accept it at face value. Now, if you're working for a system like Kaiser, which may have a different internal procedure, then follow that.
Medically vulnerable, that's what the term should be, right?
Correct.
Okay, thank you. Next one is, what is the current thinking and progress on a vaccine passport?
There hasn't been a lot of discussion about this, and frankly, the horse may have already left the barn, since those of you who've already got your 2 shots know that the record is just a printed card with the CDC's logo. There is no authentication, and I was actually reading an article today that indicates there's already fraudulent copies which have been turning up in some places as travel documents. The IATA, which is the International Air Travel Alliances, talked about a vaccine passport app for airlines to use, but it is strictly voluntary. And with the patchwork of vaccination registries in the United States, for example, we have CARE, other states have their own, some regional ones. Not even the entirety of California is on the same vaccination system. It could be a huge undertaking to link it all up. This is, of course, independent of the larger question to find, like I mentioned before, that balance between vaccine incentive and also recognizing that all the vaccines right now are still under emergency use authorization, even though by now I think we have very good evidence of their efficacy and safety. I actually currently occupy the HHS Region 9 seat for the National Health Officers Board. And on the calls that we have at the White House, there has been no mention of the idea from the Biden administration task force, nor is there very much interest from the state of California. And I suspect that the hope is that we get to a point where enough vaccine has been shot in enough arms that it really doesn't matter
anymore. From my side, the questions are all complete. Dolores, do you have any additional questions?
There are no additional questions in the chat Dr. Singhvi?
Okay. Thank you, Dr. Cameron. And I wanted to remind our members that Dolores and her staff are working very hard to bring a lot of webinars to you. You can go to site rcmadocs.org/events. There are few events. On March 18, we have a webinar on community resources at your fingertips. On March 23rd, there is making telehealth work, and April 2nd, there is a shredding event for the members from 10 to 1, where you can bring your documents to be shredded to the RCMA office. There are certain restrictions you can look into there. Anything else?
Dr. Singhvi and Dr. Kaiser, one question just came in the chat. When will the county hit herd immunity?
Your guess is as good as mine. We also have there's also the open question of what's the magic number. And I was actually talking about this with Kim Sarataria, Director of Public Health, because at some reason we're going to, at some point, we're going to have to pick a number. For all that Governor Newsom has said about making the reopening strategy into a dimmer switch rather than a on and off switch, realistically, the public wants an on and off switch. So at some point, we're going to have to pick a line and stick to it. We're not sure what that is. I will say that we are not at that point yet. And I'll also say as a policy note, I am not, even though there has to be some level of immunity in those people who have obviously gotten COVID-19 infection before, I'm not going to rely on that because I have no idea how good it is and I have no idea how long it lasts. But at least with the situation with the vaccine is I know how much got into people's arms. I have much better experimental demonstration of the robustness of this immunity. And if we get any additional immunity from, unfortunately, a very bad winter on top of that, I'm just going to take that as icing on a very ugly cake. For the time being, however, I would not consider us to be anywhere close to that amount, which is why we can continue to recommend to people to do all the stuff we should be doing: facial coverings, social distancing, good hygiene, and staying home when you're sick. And I just saw another one, and I'll answer this one before we end. The opinion of office staff asking for hazard pay increases like Amazon. I'm not going to touch the economics question, and I'll just simply talk about, is such a situation a hazard? And the answer is, yeah, it probably is. The warehouses do seem to have a higher risk there. One of our bad occupational exposures was at a date packing house in the East County. And there were at least several deaths that were linked to that were as a result. But as far as whether this should translate into actually a pay entitlement, I am going to very politely not answer that question. And then Dr. Lee, hi, Dr. Lee. Oh, goodness. Okay, so all the questions are coming in now. That's all right. We'll try and answer them.
Thank you.
Any county guidance on allowing visitors to accompany patients on clinic visits or to visit hospitalized patients? The county does not have any policy on this. The state does, however. And as I mentioned, AFL 2022.6 addresses this specifically for SNFs. We are told by the state that they will be working on something analogous for hospitals and healthcare facilities, but we do not know when that will be available. And finally, Dr. Gonzalez asked, should we expect extending the 90 days time benefit given to those that are vaccinated? Do we have any data from other countries? The answer is maybe and not yet. Because I'm also getting the question, at 90 days, are suddenly we no longer immune? We don't know. The 90 days rule is, I think, primarily come from the experimental observation of people who have had COVID-19 infection before, that we believe their immunity or whatever immunity that they possess, to whatever extent they possess it, seems to last around that long. It is entirely possible, however, and given how wildly successful the mRNA vaccines have been, that it could actually be much longer than that. And I think that as the data improves, we're going to find that out. But right now, we don't really have enough data to say, and that's why the CDC has hedged its bets with the current guidance and saying days 14 through 90. As I mentioned, the state is likely to mirror the CDC's guidance on exempting them from quarantine during that period, and it is expected that they will probably do some other clarifications as well for other parts of case investigation.
Thank you very much. Please stay safe. Good night.
Thank you.
Good night. Thank you.